Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you so much, Brian. I am delighted to be able to share with you the new recommendations for infant feeding and prevention of pediatric HIV infection in the U.S., which were released on January 31st of this year. And I hope by the end you'll have an idea of what they are and why we have released them now. I have no disclosures. This is just letting you know that HRSA is funding this, and that data in this presentation offer a limited perspective of how systemic, social, and economic factors impact health, and we recognize that racism, not race, creates and perpetuates health disparities. And then I just want you to know that I may use breastfeeding and chest feeding interchangeably. When I say breastfeeding, please also hear chest feeding. Also, research done in the past on this topic has investigated cisgender women, and so results are therefore reported on women. So by the end, I hope you can describe the changes in the perinatal guidelines related to infant feeding and explain the science and the social context that supported those changes. So first, to give you a little bit of history about what the guidance has been around feeding choice for infants of people with HIV. In 1985, the CDC in their MMWR came out and said that HTLV3, which was human T-cell lymphotropic virus / LAV lymphadenopathy associated virus, infected women should be advised against breastfeeding to avoid postnatal transmission to a child who may not yet be infected. Then 2015, perinatal guidelines. What happened was that there were a number of us on the guideline panel who said, you can keep saying don't breastfeed, but our reality in the trenches is we have some women who are going to breastfeed. We can tell them not to, but we're going to push them under the radar if we don't address this. So in 2015, the perinatal panel allowed the following. In discussing the avoidance of breastfeeding as the strong standard recommendation for HIV-infected women in the United States, the panel notes that women may face social, familial, and personal pressures to breastfeed despite this recommendation, and that it is important to begin addressing possible barriers to formula feeding during the antenatal period. That was the end of it. And that was as much as we were allowed to put in. And then in 2018, the head of the panel came to a couple of us and said, it's time for a section on breastfeeding. And I mean, I was really, and I said to him, I said, are you trying to get me kicked off the panel? Because there was a lot of opposition to this. I said, if you want me just to resign, I'll do that. But he said, no, it's time. And so 2018, this was the wording, and I think you'll be able to hear still quite a bit of negative language. Breastfeeding is not recommended for women living with HIV in the United States. Women who have questions about breastfeeding or who desire to breastfeed should receive patient-centered, evidence-based counseling on infant feeding options. And when women with HIV choose to breastfeed despite intensive counseling, they should be counseled to use harm reduction measures to minimize the risk of HIV transmission to their infants. So it was a next step. But yeah, it was still pretty negative. So what changed this year? And you don't need to read all the fine print, but just the reason I show you this slide is what you see highlighted in yellow is all new wording, new information. Just it's letting you know these are all changes in the guidelines. And the major change and the main message is that the primary recommendation is now to support parental choice through shared decision-making rather than giving or recommending a specific infant feeding mode. So just to give you some background into what led to these changes, one is we recognized the health benefits of breastfeeding. And as many of you know, I mean, in the infant, all the breast is best messaging it comes out because there's a lower risk for infants developing asthma, obesity, type 1 diabetes, respiratory disease, otitis media, SIDS, GI infections, and necrotizing enterocolitis. And for the breastfeeding parent, there's documented decreased risk of hypertension, type 2 diabetes, and breast and ovarian cancers. There are equity considerations, and we recognize that Black women are disproportionately affected by HIV, and people of color experience a greater burden of many health conditions that may be alleviated by breastfeeding. So here we were already taking a population with certain health burdens and further discriminating against them. And there were cultural considerations, environmental, social, familial, and personal pressures to consider breastfeeding, and the fear that not breastfeeding would lead to disclosure of their HIV status. So first of all, what is the risk of HIV transmission via breastfeeding? Without maternal antiretroviral therapy or infant prophylaxis, the risk of an infant acquiring HIV through breastfeeding is about 15 to 20% over 2 years, and that's just too high. But achieving and maintaining viral suppression through ART during pregnancy and postpartum decreases breastfeeding transmission risk to less than 1%, but not zero. And the most recent data is from Pat Flynn, published both in 2018 and 2021, where they had a risk of 0.3% or 3 per 1,000 in the first 6 months, or 6 per 1,000 in 12 months. But these were not all ideal scenarios. And among the 2 women who had viral transmission to their infants via breastfeeding, they were undetectable on the date when their baby was diagnosed, but when you looked at their serial viral loads, they were not fully suppressed at delivery or close to delivery, and they were not the ideal candidates. And these are not the people that we're talking about as being good candidates. So at least right now, we have to say it's the transmission risk is not zero on ART, but it certainly is probably well under 1%. So this is some of the new wording. And I really want to emphasize that for people with HIV who are not on ART and or don't have a suppressed viral load at delivery, replacement feeding is recommended, and that's formula or bank pasteurized donor human milk. When we're talking about infant feeding and talking about breast chest feeding, we are talking about people who are well suppressed. And the wording is that individuals with HIV on ART with a consistently suppressed viral load during pregnancy at a minimum during the 3rd trimester and at the time of delivery should be counseled on the options of formula feeding, bank donor milk, or breastfeeding. And what we specifically say now is to the people who are thinking about breastfeeding, the infant feeding options that eliminate the risk of HIV transmission are formula and pasteurized donor human milk. Fully suppressive ART during pregnancy and breastfeeding decreases breastfeeding transmission risk to less than 1%, but not zero. And then, there always are the situations where suddenly somebody is not fully suppressed. And so in the case of a detectable viral load while breastfeeding should be temporarily stopped. The options include giving previously stored breast milk, pumping and flash heating, which is basically putting the breast milk in a water bath for 20 minutes, water that has been boiled, providing replacement feeding or cessation of breastfeeding, repeating the viral load, and reassessing continuation of or cessation of breastfeeding. And obviously, a viral load of 21 is going to be different from a viral load of 2100 in terms of how you're going to counsel someone to proceed. If the repeat viral load is detectable, the panels advise immediate cessation of breastfeeding, and this guidance is more directive than the other counseling where we are suggesting more choice. And then an area of great debate, there's no consensus on ARV prophylaxis for infants of individuals with sustained viral suppression who are breastfed. And I'll go through the range of what is being done, but we really don't have a specific recommendation at this point. So most of the panel members agree on only, now it's 2 weeks of infant zidovudine. It used to be 6, then it was 4, and now 2. However, several panel members prefer to extend it to 4 to 6. Alternatively, some panel members recommend 6 weeks of nevirapine, as currently recommended by WHO for breastfeeding infants at low risk of HIV transmission in resource-limited countries. And others opt to continue nevirapine dosing throughout breastfeeding, which is what our pediatricians in Houston have opted to do. There's also a lot of new content on how to support breastfeeding and weaning, how to monitor parents and their infants and manage specific situations, but a lot of it is based on expert opinion. And here's some of the gaps that still remain. We have no studies that have so systematically evaluated the risk of HIV transmission through breastfeeding when maternal ART is started before pregnancy or in the first trimester and continued through breastfeeding. And we have no data to inform the appropriate frequency of viral load testing for the breastfeeding parent. One other new piece is that engaging child protective services or similar agencies is not an appropriate response to the infant feeding choices of an individual with HIV. And there have been a number of pregnant people with HIV who have reported that after expressing their interest or intention to breastfeed, their providers threatened to report them to child protective services or actually did. And as you can imagine, such engagements can be very harmful to families. I mean, this is then often taking a child away. They can exacerbate the stigma and the discrimination experienced among people with HIV and are disproportionately applied to minoritized individuals, including Black, Indigenous, and other people of color. And I had heard stories about this, but had not encountered it until about 2 years ago when we had just decided to start having an agreement in our practice that patients would sign, OB would sign, and the pediatric ID person would sign all prior to delivery, just saying, I understand that there's not 100% guarantee that my baby won't get HIV through breastfeeding. I understand that I need to continue to take my medication. I understand. So there were like a dozen things to initial and sign. And the first person that we used this on, she had her baby and she was able to show this in the hospital. It was in her chart, just documenting this has all been discussed. And a few months later, she went to WIC for getting some supplementary food. And she said, I have HIV, I'm breastfeeding. And they said to her, oh, well, have you talked to our lactation consultant? And she went to the lactation consultant and said, I have HIV, I'm breastfeeding. And the woman's eyes got really big and said, I will have to get back to you. And 2 days later, Child Protective Services was knocking on her door. And they said, we understand you have HIV and that you're breastfeeding. And so she went and got her document and she waved it in front and said, look, but my doctor signed it and my baby's doctor signed it. And the CPS worker said, oh, I'll get back to you. And so she, I think it was on a Saturday, and on a Monday, she came into our clinic and she told me the story. And so I got on the phone and we called WIC, we called the lactation people, we called the CPS, and we explained that this was okay in this situation. And they backed off, but it certainly could have ended very differently. So one other thing that was different in this round of developing the guidelines are updated every year. And this time we integrated community input from members of the WELL Project. And if you're not familiar with the WELL Project, I recommend Googling it afterward. It's an advocacy organization for women with HIV. We also included members of the international community of women living with HIV in North America and some other individuals, some of whom have HIV and have breastfed. We got input from lactation specialists at CDC. And we had a new level of collaboration between the perinatal and the pediatric panel. So usually perinatal panel does their thing, pediatric panel does their thing. We are aware of what they're doing. But this time, after we came up with our guidelines, we sent them to the pediatric panel and they went through a very complete critique. And, even though it took much longer, I think it was time well spent. And by the end, it was the perinatal and pediatric panels really working together. One other big change is that CDC chose to refer any queries about infant feeding in the US to the perinatal guidelines. So going forward, rather than them having their own recommendations, and I really hadn't thought about it until one of the community members said to me, where doctors go when they're not sure about something health-wise, like infant feeding and HIV, they go to CDC. And it, suddenly a light bulb went on for me. That's where I go when there's something I don't know. But for the perinatal guidelines, that was my world. And I just figured, everyone knows the perinatal guidelines, but they don't. And so this is a huge step to really bring all of the recommendations under one umbrella. And so from here on, CDC is saying, go to the perinatal guidelines. And the change in the guidelines also, it parallels the increasing interest among providers across the country. And this is a graph of calls to the National Clinician Consultation Center or perinatal hotline out of UCSF. And if you look, you can see that in 2014, less than 5% of the perinatal calls were about breastfeeding. In 2022, over 25%. And so this has definitely been on many people's minds. And there's also a great study that was initiated by a group of pediatric residents at UCSF. They sent out surveys to clinicians who might have reason to be interested in this subject, and got close to 100 participants and asking them questions about their feelings about infant feeding. And I think they really nailed it when they, if you look at this seesaw with provider discomfort at the fulcrum. And on one hand, it's doctors wanting to recognize patient autonomy and, respect the patient. And then on the other end is what if there's a baby who gets HIV while breastfeeding under my watch, and just all the reasons why someone might be scared to support this. And so just a few samples of comments made by the clinicians. I feel the need to protect the infant and think it isn't ethical to put the infant at increased risk. Therefore, we have to this point only allowed women with stable suppressed viral loads to breastfeed their infants. And I would actually support that, because really if someone's not virally suppressed, we do not recommend breastfeeding. Provider disagreement. Some of the providers in our small group believe that our guidelines should be liberalized. Other providers feel we should not allow breastfeeding among women living with HIV under any circumstance. It's been difficult to get consensus. And lack of guidelines or data. I would not feel comfortable because there aren't specific guidelines or literature to support the care. However, I'm very interested in learning more for those who are interested in breastfeeding to be able to support that decision. So I think it just they really were able to capture all the questions and discomforts that came along with those questions. And then patients, it's been confusing for patients. They've struggled to navigate infant feeding in the absence of more guidance. And in the center is Cece Coven, who has been a very articulate advocate, who was not allowed to breastfeed her first child and who did breastfeed her second one after a lot of consideration, and has really become a spokesperson for pregnant people with HIV. And she said, it's very important that we're given a choice. Like, I just need you to support what my decision is. It's not my provider's place to tell me what to do with my life or my babies. I just need you to leave the space open for discussion and choice. Some resources for you as we all navigate this new road. One is where you'll find the guidelines, and that's the www.hivinfo.nih.gov. And you just then come to guidelines and click on that. And then you have a choice of the adult guidelines, the pediatric, the perinatal. And then I ask all of you to take out your phones and put this number in. And this is the perinatal hotline. It is a 24/7, 360 days a year service where you actually get to talk to a human being. And so at 3 a.m, you have a patient newly diagnosed with HIV and you say, oh my gosh, what was it that they talked about? You call this number. And it needs to be no fear of, I have a stupid question. They are accustomed to dealing with the most basic and the most complex questions. I work with them. I have on occasion called them and they've said, Judy, what are you doing calling? It's like, I just need another person to bounce this off of, because I know there's no right answer, but when two heads are better than one. And so they are really very, very knowledgeable and very, very nice. And I think offer a very remarkable service. They also have a warm line for general HIV service. So it's not 24/7, but most hours of the day. They have a hepatitis hotline, a PrEP hotline, a PEP hotline. So they really do some great things all around the country. And I just want to acknowledge our patients, who are the ones, as I was telling Brian just before this started, our patients are the ones that taught me that this was an issue at all. And early on, when I started taking care of pregnant people with HIV, I just said, oh, we recommend formula feeding. And then it was some of our African women in particular who educated me that they might have to breastfeed. And so they are really at the core of this: the perinatal HIV panel, the pediatric panel, the CDC, the Office of AIDS Research Advisory Council, the Well Project. And then the specific people. Deb Storm is the person who has taken all of the panels through the many edits and that it took to reach consensus, and she just does a remarkable job. Athena Cordes has been our voice at CDC, and then my colleagues Leila Pollack, family medicine at UCSF, Ted Rule, pediatrics at UCSF, and Elaine Abrams, pediatrics at Columbia, all contributed to making this happen.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.